The first question is, I have been able to tell if a child has an ear infection because I can see the redness. When someone says they can see fluid, where are they seeing that fluid?
No, that's a good question. So seeing the fluid itself, generally speaking, if it's clear, it might not be super obvious just on otoscopy. Sometimes it's more evident to me actually when the fluid's developing or going away because I see some bubbling behind the eardrum. That tells me the fluid was there and it has maybe started, the eustachian tube starting to function again and things are dying down. You might see if there's cloudiness behind the eardrum. That would give me an indication that perhaps there's some infection at play. But in general, the other piece too, if the eardrum's really bulging, like it looks like it's bulging towards you when you're looking in, that would also give me some indication that perhaps there's fluid behind the middle ear, behind the eardrum.
Okay, and sort of a couple follow-up questions to that. Is that an early sign of infection, or is it the infection itself once you see the fluid?
So just the presence of fluid doesn't really give us any indication of infection. And it's a little bit of a challenge. Protocols have really changed over the last several years about how to handle middle ear pathology because in the past, a lot of kiddos with fluid were given antibiotics fairly quickly. And then what they found is that antibiotics weren't really necessary. There were viral cases, or maybe the fluid wasn't infectious at all. It was just there and it was bothersome from a hearing perspective. So it's really going to depend. It's hard to say for sure. I would definitely, if you see redness or if you see, some cloudiness to the fluid, I'd be more suspicious of an infection. I'm not an ear, nose, and throat physician, so I would probably defer to them, obviously, to make that call.
Okay. And can that condition or that sort of fluid buildup lead to hearing loss?
Yeah, so that's a good question. There are a few different things to keep in mind with that. If you just sort of have a random transient ear infection, it's probably not going to have any long-term impact. When you see kiddos that have chronic issues, ear infections that last for months or fluid that lasts for months, so basically creating a conductive hearing loss, that's when they might get referred for tubes that are placed in the eardrum to prevent the buildup of fluid in the future. The other piece for that, when we have kiddos that have chronic middle ear issues that aren't treated, we might see something called a cholesteatoma, and that can actually be a really serious diagnosis in that it's the buildup of cells and it sort of forms a little bit of a tumor and it can encompass the middle ear space, erode away at the bones, things like that. Not super, super common, but that's the worst case of a chronic case that is not addressed.
Okay. Are there financial resources for families who are not following through because of that type of barrier?
That is a good question. The financial resources that pop into my head immediately are more around hearing technology, if insurance isn't covering it, but for the evaluation itself, I'm assuming is the question. Generally speaking, insurance should cover it if there's a medical necessity. So it might be a matter of discussing with the primary care provider around how that referral is made to make sure it's something that insurance is going to be able to cover. I would argue that, if you have a child you suspect has a hearing loss, there's certainly a medical necessity in clearing that up and either getting a diagnosis or ruling it out.
And have you seen any increase in hearing loss from the increased use of headphones and earbuds? Have you noticed like a trend at all?
Yes. I don't have the citations off the top of my head, but that's been a pretty hot topic, a big research area over the last decade or so, that, in the sort of middle school, high school ages, starting to see more noise-induced hearing loss. That's where it might not hurt. I talked a little bit about what Maine's minimum recommendations are, but I'm certainly happy to talk to anyone about maybe adding an additional grade of screening if they're concerned about anything like that. I'd have to look back to my professional organization, but I think there is a recommendation of doing it again in middle school. I think maybe like 7th grade, don't quote me, to again sort of look at those kiddos that may have acquired noise-induced hearing loss.
Okay. And do you have any pictures of the TM/fluid on otoscopic exam? I don't know if I said that right, but
Um, I don't know if I have it offhand, but I can certainly get in touch with you with some resources for that if you'd like.
when I ask an elementary student to raise the hand of the ear they hear the sound in during testing, they often raise the wrong hand, and I don't know whether they heard the sound in the correct ear. Do you pass or fail that student?
Oh, thank you for asking that. That's a great question. I myself don't ask them to indicate an ear. I think it adds another sort of cognitive level to the screening that could be tricky for some kids. So I accept regardless of what hand they raise because I know which ear I presented it to just by looking at the audiometer, if that makes sense. So if they raised their hand or responded however you asked them to, don't get too concerned about which side they're saying it is. I would still count it as a pass if they're responding reliably.
Okay, and kind of a follow-up question on the audiometers is, do you recommend audiometers that ask for child's response or electronic screeners so that, like the Welch-Allen makes one that its inserted probe measures hearing?
So the screening that I've discussed today, and that's most appropriate based on developmental age for this preschool through I think fifth grade is what I said group. It would be behavioral testing, so requiring a behavioral response from them. There are situations where you're going to have students that can't do that. Um, I don't believe that Maine has any specific regulations if a child can't participate in the screening that you would have to then find like a more objective measure to screen them with, like an otoacoustic emissions is probably what you were referencing. Um, but I could look into that for you to confirm. That might just be a situation where they need to be evaluated by an audiologist if it's something that they can't do at the school in terms of the screening.
Is there a handy tool you would recommend for documentation and follow-up, or how about like a template referral form that you like? Any certain documentation tools that you like?
In my experience, districts all kind of use their own, but I'm happy to look for some templates to at least get you guys started. Really, the basics of having like an easy chart to document whether or not they responded to each of the screening frequencies. And then also, generally, how I've seen it done is to have that and then also have a section for you to quickly fill out to say, okay, they referred on the screening, so you can give a copy of that to the families with whatever the PCP needs to complete listed
Okay.
at the bottom.
Is it correct to move the DB dial from, say, 25 to 30 to get a positive response and then forward this information to the PCP?
I would say don't spend a lot of time doing that because then you're sort of almost moving into a threshold seeking territory. I would leave it as sort of a pass fail and then let the PCP sort of determine from there, again, whether or not they want to do the screening again in their office or if they want a full diagnostic evaluation from an audiologist.
Okay. Um, and then we also had a question around in the student health record, how do you record the screening results, pass/fail or actual DB?
You could say, passed when screened at 25 dB at, 1,000, 2,000, 4,000 hertz, if you want to really document it well, exactly what you did. Or you could say, passed at all screening frequencies except 1,000 hertz in the right ear, again, to be as detailed as possible.
Okay, and along the same line of questioning, if 25 dB is considered slight hearing loss, why are they considered passing at that level?
That's a great question. I read a lot when I was preparing this about that topic. And really, it comes down to the understanding that screening isn't really happening in an audiometric test booth. So we know that it's going to be a little bit noisier in the environment than it would be for an audiogram to be completed by an audiologist. And then also not wanting to make the screening so stringent that you're going to catch a lot more children that don't actually have a hearing loss, again, because of things like background noise and the environment being a factor.
This question kind of goes more into what do we do if a student's failed, the referral happened, the parent did not follow up, this person's followed up several times and they still haven't taken the child in. Is this at that point like a DHS referral because the child's hearing's really impacted?
That is a really good question. The other piece I would say too, just as a consideration, if I don't know if the parents would be agreeable to this, and there's obviously the need for releases, but if you have a really strong suspicion that there's a hearing loss, but you're having trouble getting the family to go to the audiologist, you could always reach out to my organization, the Maine Educational Center for the Deaf and Hard of Hearing, especially if many of you may have already met some of my TOD colleagues that work in your schools with students. They might be able to just communicate with the family and get their impression and help sort of support that process of getting them to the audiologist to get that diagnosis going.
Yeah, and there's kind of a few questions around that. So it seems as a theme, asking for any advice on how school nurses and teachers can team up to help parents understand the need for that follow-up when they're, that hearing loss or issue is diagnosed. So there's probably 3 or 4 questions around that whole piece. So it seems like that seems to be a barrier.
Yeah, I mean, I'd say document. So anything that from the teacher's perspective that they're seeing in the classroom that's consistent with hearing loss, whatever the results were from your hearing screening. And really, again, reaching out to me, even if you want to just shoot me an email with non-student specific info, I can try to get you some resources to help with that process.
Great, thank you. So someone asked, we have several students with cochlear implants or cochlear implants. How well can these students hear and what are they hearing?
So without their devices, they're not hearing anything. They have a severe to profound hearing loss, so only very, very loud sounds, generally speaking. Of course, without seeing their audiogram, but generally. And then with the devices, usually the devices are programmed in such a way that we want them to be hearing sort of in that 0 to 25 decibel range, and that has to do with really the limitations of the equipment itself. Yes, 15 dB is really great, but sometimes we can't hit that 15 dB mark without maybe preventing their ability to adequately hear louder sounds. So there's a little bit of finesse at play. This all assumes that they're seeing their audiologist regularly, having the device programmed, reprogrammed, and that the equipment's functioning normally. The other piece that I will put out there is sometimes changes in hormones can impact how they're hearing through their cochlear implant, which is a very unique thing. So that's sort of the importance of that follow-up with their audiologist, especially as we start seeing, late elementary, middle school age children experience some changes.
So when a student has a lot of earwax, which impedes a visual of the ear, what is the best recommendation for wax removal?
It's so tricky. I would probably be referring on to at least their PCP to make that determination. I know there are some over-the-counter products out there, and I'm always hesitant to make that recommendation, especially if you're not really sure about the condition of the eardrum behind it. Say you had a kiddo that had an eardrum perforation, you don't want to put anything extra in the ear with that space open. So I would make that referral to the PCP. Sometimes the PCP can actually remove it in office, or they can refer to an ENT that can.
What kind of cleaning do you recommend to use between the students of the headphones? So cleaning of the headphones between students.
No, that's a great question. There are some products called audio wipes that might be appropriate. I'm thinking about emails I've just received in the last week of how to appropriately clean different hearing related devices, and I believe that was one that was mentioned.
So a follow-up question on the electronic screener. The district they're in purchased one, and some nurses use it as it is quicker and some feel more reliable. Do you recommend them?
I'd probably need to know a little bit more about what the actual device is doing just to be able to speak to that. And I would also probably want to double check chapter 45 to see what they recommend, if that sort of meets their minimum requirement.
In the past, I was trained when a child couldn't hear at 25 dB to go to 45 and work your way down to see when they, when they would be able to kind of hear that. Is that still appropriate?
I think it's not that it's necessarily inappropriate, but it does kind of move you from a screening to looking a little bit more diagnostically, and it's probably going to take a lot longer to do it that way. And either way, if they're not responding at 25 and you're finding they're responding at 30 or 35, your outcome's still the same. You're going to refer them. So I think in terms of efficiency, it might not be worth the time. As I mentioned before, you can kind of do the whole conditioning tone. You can throw out a louder tone just to kind of get them used to what they're listening for, but then just return to 25 and screen them there.
Mm-hmm. And somebody asked, is there any value in screening at 6,000 and or 8,000 dB? This used to be the recommendation.
It's no longer part of the screening protocol. And I think 6,000 and 8,000, there are some different reasons why hearing might be impacted there, again, including ambient noise. I think individual school districts can probably go a little bit above and beyond what the minimum requirements are from the state if they want to. But I would probably want to do a little bit more research to determine if there's a reason why screening at 6 and 8 wouldn't be valuable. I think adding 6, if I'm remembering correctly, what I've read with my professional organization's recommendations, adding 6 can have some value if you're looking particularly at noise-induced hearing loss, because background noise is going to impact higher frequencies first. Or excuse me, excessive noise is going to impact higher frequencies first.
Great. And do you have any additional information, or can you clarify why hormones can affect the cochlear implants?
I don't know if I actually know the mechanism off the top of my head. I just know that that's sort of the conventional wisdom, is that, when someone gets a cochlear implant early on, there's a lot of early appointments to get their maps set to such a way that they're hearing the way we would like them to. And then we see that remain pretty stable over time with some minimal changes as they go for follow-ups. And then I think what's been found by a lot of my colleagues who do more cochlear implant mapping than I do, was that around that puberty age is where we start to see some shifts in maps and where things are getting changed a little more drastically. And I've sort of seen that informally in my work with children in different school settings, is that I've seen a few kiddos that, wow, they're not hearing as well as they used to with their cochlear implant, and then found out, oh, their map was just really inappropriate for them now.
Hmm.
So fortunately, it's something very easy for the audiologist to address. So I think if you see that a kiddo has always responded pretty well, and now suddenly the equipment looks great, it doesn't look like there's anything broken or not functioning the way it normally does, but they're still not hearing well, definitely referring them to their audiologist to get that checked out.
Okay. And if a child does go to an audiologist and they say the loss is not significant enough to do something about it, do you ask for written info from the audiologist, and what could be their next step to provide assistance or classroom accommodations?
Yeah, I would definitely ask to see their written report, and you may even want to see the audiogram itself. It's not a bad idea to have that in the student's file as part of the info you collect about the follow-up to the referral. Certainly, I can see cases where perhaps they're not great hearing aid candidates, but if there is truly some hearing loss, and especially if you're seeing some impacts in the classroom setting, they still might qualify for services, even through my organization, MECDHH, maybe even just a one-time consult from one of our providers to observe them in the classroom and make recommendations to the educational team.
Okay. Do you think school nurses should be doing, is it impedance testing?
Yeah, impedance testing.
Yeah.
I don't think there's anything in Chapter 45 specifically indicating that you should. I don't know that there's anything that would indicate that you shouldn't, but I think it's really dependent on obviously what equipment you have available to you, and again, are people trained in using it and interpreting the results, and how are you going to use those results? Are you doing that middle ear screening to then refer them to their primary care provider? Yeah, so I think it's just a matter of coming up with a protocol for that.
And do you recommend screening children who have known permanent hearing loss and they are already under care?
I do not. I would just document that. I think as long as you have documentation of the hearing loss on file, that should probably cover your bases. Certainly, if you hear otherwise, let me know or let Emily know. But I would think from the state standpoint, if we know they have a hearing loss, there's probably not much of a use of screening them for hearing loss.
Okay. And if someone finds a student with an apparent hearing loss, should we conduct a more thorough evaluation to send with the referral or just make the referral?
I would just make the referral, but I would make sure that the parent and the PCP have the results of the screening. I think it's important for the audiologist, if that's where they end up being referred, knows what's happened, so they kind of have some context. And certainly if you want to include, if the school has specific concerns about the child's, learning or behavior in the classroom that looks consistent with a hearing loss, including that information too does not hurt.
So is it considered a pass if they raise either or both hands when they hear the tone, even if it's not the correct ear? So again, this gets to like, which hand am I raising? And
yeah, I would not get caught up with I don't even instruct to say like, raise your right hand if you hear it in your right ear. I just say, raise your hand when you hear the tone. Because I think it adds another layer of cognitive load on the child when they're trying to do the screening that might sort of muddy your results. So I would not, as long as they're responding in whatever way you're hoping, and again, not focusing on right or left ear, then I would consider that a pass.
there's a lot of training on the Head Start website that is from the ECHO initiative for preschool age children, showing how to conduct testing, problem solving. Someone just wanted to know if you're familiar with that and if you recommend it.
I believe I am. I think their focus, and you can correct me if I'm wrong, because I might be thinking of something else, might be more on otoacoustic emissions and not behavioral screenings. But it's still, if that's the case, it's still really, really useful information, particularly if your program, your preschool setting is going to conduct screenings using otoacoustic emissions.